All right, let's try that again. Good morning, everybody. Thank you. Thank you. I love a good NAMI good morning. My name is Dr. Ken Duckworth. It's my great good fortune to be your medical director, the best job in American psychiatry. And I deeply know that and appreciate it every single day. This Saturday morning time is reserved for updates on research. And we're very fortunate today to have Dr. Robert Heinzen as our speaker. Dr. Heinzen is on one of our 3 pieces of the strategic plan, getting people treatment earlier. For the last 20 plus years, he has been on this issue in his leadership role at the National Institute of Mental Health. So the Recovery After Initial Schizophrenia Episode Project, the North American Prodromal Longitudinal Study, EpiNet, which he'll be talking about. This is all part of Dr. Heinzen's vision for how treatment should be organized. I will also say he's been an incredible friend to NAMI. We call him, we ask him to do things, he invites us over. He's into us. He's one of us. A fun fact about Dr. Heinzen is he served in Afghanistan. He was a vet in the reserves and was called to Afghanistan. So Dr. Heinzen is the real deal, and I submit to you the best use of taxpayer dollars that exists in America today. We're going to be handing you index cards. Write your questions for Dr. Heinzen. Somebody, raise your hand. Somebody will write your question down. At the end of his talk, I'm going to go through the questions and ask Dr. Heinzen all of them. Thank you very much, and please give your best NAMI welcome to Dr. Robert Heinzen.
Good morning, everyone. So let me ask, how many people love science? Show of hands. Yes, yes, you're my crowd. So it is, well, first of all, Ken, thank you so much. I don't believe that I have ever gotten an introduction that comes quite close to that. So thank you, I appreciate that. So today I'm going to be talking with you about some science that the NIMH has both completed within the last several years and give you an idea about what's coming up. And all of this organized around the idea about how can science help people with early serious mental illness. So before I launch into that, my disclosures, I don't have any financial conflicts of interest to declare. And also, today I'm speaking as an individual and not as an official representative of the US government. That protects my boss against anything that I might say. So I was really excited when I saw the agenda for this meeting. I know that there are 3 tracks: personal change, societal change, and systems change. And it gave me an idea that what I wanted to talk about was research that we've been pursuing that addresses NAMI's goals about accelerating innovation in healthcare systems with the goal of improving access and improving outcomes. So I'm going to structure my talk around that and use the idea of learning healthcare as the framework for this talk. So learning healthcare was a concept that was developed by the Institutes of Medicine over a period of several years, where they were looking at what was wrong with American healthcare and what was the path forward. And after many meetings and several publications, in 2013, they published this resource, Best Care at Lower Cost, and it summarized what the principles of learning healthcare are and how they might be applied in the future to improve healthcare in the United States. So you can distill this into 5 principles. Basically, it starts with, let's start with offering the best care possible, evidence-based care, and what we consider the best standard of care. And when we provide that, let's provide it in a context where we measure the results of that care at the individual level. So we're actually accountable for interventions provided to people, and that we're looking to see whether they work or they don't work. And then if we have a way that we can take those data from individual encounters and pull them together and be able to analyze that, we can look for signals about quality or lack of quality. And if we find places where quality is deficient, we can launch some initiatives to try to improve those services, to bring services up to the place where we are getting the outcomes that we hope for. And when we do that, again, we measure. And we look to see how those improvements are working out. And sometimes they will, in fact, lead to improvement, and that will be great. Sometimes they'll lead to improvement far greater than we expected. That would be interesting. And sometimes they lead to results that are disappointing. And that's a cause for concern. And those interesting findings and the cause for concern bring us to the point where now we have to speculate, wonder about, so what is it about our treatment that is not working? What about this illness or this condition don't we understand? And those data become the fuel for scientific discovery. We launch new research, and theoretically, that research then eventually feeds back into the healthcare system, further improving the care. That's a wonderful model. It hasn't really been applied to mental health very broadly. So I just wanted to talk for a moment about the case of schizophrenia as an example of serious mental illness and how learning healthcare has not yet been. Okay, I'll try not to. I was moving my hands. I got to the wrong slide. So schizophrenia is a mental health condition that alters a person's perception, their thinking, and their behavior. In medical terms, auditory and visual hallucinations, delusions, difficulty with attention and memory, difficulties with social functioning, work functioning, and so forth, disorganized behavior. These are all characteristics of the disorder. And they appear early in life, usually somewhere between adolescence and young adulthood, and are disruptive of the person's journey towards becoming an independent and contributing member of our society. It's not a common, but it's not an unusual disorder. Somewhere between 1 and 2 million Americans suffer from schizophrenia. And all of that is kind of a description about the basic features of schizophrenia. But these next two bullets are a statement about what a care system that often delivers treatment in a delayed manner and in a fragmented manner, what kind of outcomes we see from that system. And it's very common for people with schizophrenia to be unemployed, to be homeless, and as I heard in several presentations yesterday about crisis intervention teams and the intercept model of community care provision, very often the first encounter with the treatment system is through the criminal justice system and ending up being either arrested or in jail and having your first episode of care through that means. Those are not outcomes that we can be proud of, and over time, that poor care actually has a result that people die up to 30 years earlier than those from the general population. Early in the course of schizophrenia, the risk for suicide is quite high, but in latter years, it's undiagnosed and untreated medical conditions that are the cause of early mortality. Respiratory illness, cardiovascular disease, obesity, all of these things are highly treatable, but are rarely screened, and people are rarely referred to treatment. That's not a very good way of organizing care for individuals with serious mental illness. And we know from research that NIMH launched in 2008 that there are some things that we know about what contributes to that poor care. I already mentioned that treatment is often delayed for people when they have a first episode of psychosis, the hallucinations, the delusions, the disorganized behavior that are dramatic expressions that something is wrong. Surprisingly, on average, people need to wait 18 months before they get into a treatment situation that is adequately addressing those kinds of problems. That's a long time for not only to be suffering, to have these symptoms, but it's a long period of time to allow other bad things to happen around those symptoms. Crisis services, encounters with the police, and all sorts of bad things. So treatment is delayed. And when treatment starts, we know that it's not always at the highest standard of care. In our RAISE study, the Recovery After Initial Schizophrenia episode study, for the people when they started that investigation at baseline assessment, roughly 40% of those individuals were receiving medication regimens that did not comply with the known standards of care. They either were not getting the kind of antipsychotic medication that was recommended for first episode psychosis, or they were receiving polypharmacy, multiple medications, or the doses were outside of the recommended range. So if 1 out of 2 people are not getting the best standard of care, we know that there's a problem. And in the RAISE study, these health problems that I mentioned a moment ago, the cardiovascular risk factors, were very common in this young population. Average age was 23 in this study, and people actually showed metabolic profiles that were more consistent with somebody in their early 40s than their 20s. And as surprising as that fact was, the shocking thing was virtually none of those individuals were receiving medical care to modify those risk factors. All of that together, maybe it wasn't so surprising that we also found the risk for mortality was quite high during the first year of psychosis. This was not part of the RAISE trial. This was other research that was done, but we found, looking at other data sets, that people with first episode psychosis are anywhere from 3 to 8 times more likely to die during the year after their initial diagnosis than people either from the general population or people who have an initial onset of depression, often by suicide. So this is a very alarming picture about what typical care is like in the United States. And it's particularly shocking because we know that there's a better way of offering treatment. There's research that comes from around the world, from Europe, from Australia, from Canada, that has illustrated that early intervention in psychosis really makes a big difference. And that, I'll talk about the nature of that treatment, but a combined treatment package that addresses the medication needs, the psychological therapy needs, the family education and support needs, the rehabilitation needs around school and work. When you put all that together in a package, it really can have a dramatic impact on the immediate outcomes for people with first episode psychosis. Their symptoms improve quite rapidly. There are fewer relapse episodes over time, less reliance on hospitalization and crisis services to manage their illness, overall better functioning and quality of life. Christoph Carell wrote a very nice review paper of these findings that was published last year, and it shows across many different countries and different contexts that early intervention matters. So when we think about that, just a decade ago, how well was the United States doing with this kind of approach to care? Well, I analyzed the mental health block grant plans for 50 states that were submitted in 2008, so roughly 10 years ago, and looked for evidence that the state plan had a firm commitment towards early intervention and was utilizing these evidence-based approaches to care. And here you can see we weren't doing too well in 2008. There actually were 2 states that had identified plans, California and Oregon, but in the mental health block grant plans, it was only Oregon that actually identified a number of programs and gave enough description to them. Go Oregon, yeah. And actually, really, go Oregon. You guys are great, and for a long time you've been great. But the greatness of Oregon was not being disseminated to the rest of the country. So we thought that we could change that around. And we launched the Recovery After an Initial Schizophrenia episode project. And the idea behind this research was to ask whether early intervention strategies could be implemented in the United States, and would we get better outcomes? So we launched it in 2008. It's taken about a decade for that project to finish, and I'm going to give you a summary about what that project achieved. So there were 3 research questions for RAISE. The first was, is early intervention feasible in the United States? And that was important because in most other countries, they have different healthcare systems, maybe nationalized healthcare or single-payer systems, whatever, but systems that made it a little bit easier to integrate, coordinate care elements into a package of services. That's not typical in the United States, not typical today, and it was less so in 2008. But we wanted to know, could researchers come up with a program that would utilize existing mechanisms to be able to put together a package of care and then make them work in real-world treatment settings? So we wanted to know, if we did this research, would it work in the real world? So that was feasibility. And then after we demonstrated feasibility, we wanted to know, would it be effective? Would we get results comparable to the studies from other countries? And then the third thing was we wanted our researchers to be thinking ahead and thinking about the challenge of bringing good programs to scale. So they needed to be thinking about a deployment focus. What would it take, if all of this worked, what would it take to make it the national standard? So those are 3 pretty ambitious goals, but we had 2 terrific research teams that took on this challenge. The RAISE Early Treatment Program was a randomized controlled trial. It involved 34 sites in 21 different states, and I'll tell you a little bit about that trial in just a moment. So that trial looked at the comparative effectiveness of this kind of coordinated treatment model versus typical care. The second study, the RAISE Connection Program, was an implementation project that involved the states of New York and Maryland, and it studied ways in which you could implement a coordinated program for first episode psychosis in the public health setting. And their job was to understand the barriers and to come up with ways of surmounting those barriers. The studies launched simultaneously, and by 2009, 2010, they were up and running and they were up and running around some of the principles of early intervention that had been developed in these other countries. And just a few of these to note. So early intervention means you don't sit in your clinic and wait for people to come to you. You assertively outreach into your community and to try to find people at earlier points in time. And then when you do find them, to engage them in a way where they feel that the treatment is inviting, relevant, and going to be helpful. A way to do that is to have a youth-oriented treatment program. That's really important for 2 reasons. We're talking about treatment for people who are moving from adolescence into young adulthood. Psychologically or developmentally, there's a mindset to be taken into account. Any of you who have survived having teenage children know that this is the case. So one thing that doesn't work well is to say, look, I'm your doctor, I know what's best, do this. Pretty much doesn't work with this group. So it's a different way of approaching people. Developmentally, there are differences. Also neurobiologically, there are differences that are important. People in this age range respond to antipsychotic medication in a slightly different but important way that distinguishes them from older people with established schizophrenia. They require far less medication to get a good treatment response. And if you go over that lower threshold of medication, they're far more vulnerable to side effects. And those side effects are discomforting enough that it makes them less interested in pursuing medication treatment going forward. So the pharmacotherapy needs to take that into account. Treatment, because the needs of people are varied, it could be their principal problem could be their psychotic symptoms, but maybe not so much. Maybe it's their distress about having left school or not being able to work or losing their friends, or their difficulties perhaps with, they've noticed some changes in their cognition and they're not able to follow conversations the way that they used to, or they can't they can't do their homework or they can't perform on the job. That's the principal concern. Or maybe it is that this experience of illness has really brought a lot of tension into the family and helping to restore some kind of better, more facilitative relationship between the person who's ill and family members is a principal concern. What you need is a suite of services that surround the person that you can then personalize to their needs. So that was part of this intervention. And then finally, that it would be personalized so that it would not be one size fits all, but it would be tailored to the needs of a given individual. Eventually, we came to call this model coordinated specialty care. And it wraps around the person with psychosis, psychiatric assessment and medication, cognitive and behavioral, so those are for the positive symptoms of psychosis, cognitive and behavioral psychotherapy to deal with the distress, the thwarted goals, the change in self-perception that often accompanies psychosis, family education and support to offer real help to families who are really looking for assistance in understanding what happened and knowing how they can be of best help to help foster the person's recovery. Supported employment and education services that are offered at school and at the job to get the person working or back in school and support them in that milieu. And if necessary, care management services to help with arranging social services. I don't have time today. Actually, I was going to say to you, I have many slides, and my slides are like my children. I'm proud of all of them, and I could spend endless amounts of time speaking about each of them, but unfortunately, I'm just going to have to plow on. I do want to say for cognitive behavioral psychotherapy, there is a workshop today that's being offered. Kate Hardy from Stanford is one of the presenters. She's a real expert in this, recognized as a national expert in CBT. So if you want to learn more about that approach for early psychosis, that's the workshop to attend. So we organized these treatment programs, and to tell you a little bit about what we found. So the RAISE Early Treatment Program, that was the comparative effectiveness trial, found that after 2 years, the coordinated specialty care treatment outperformed usual care in a number of important dimensions. People in coordinated specialty care were much more likely to be engaged in treatment and to stay engaged in treatment over time. They utilized more services over a longer period of time than usual care. And perhaps because of that higher engagement and utilization of services, they had greater symptomatic improvement, greater recovery in terms of work and school engagement, a higher quality of life, and later on we found that this approach was cost effective. So all of this was pretty good news. A group of individuals in coordinated specialty care compared to a group of individuals in usual care, coordinated specialty care did better. But there was an interesting additional analysis done in this study that told us that timing of care is extraordinarily important. You might remember earlier I said that treatment delays are very common in the United States, and the average length of time that people are ill before they get specialty care for psychosis is 18 months. So what the researchers did in this sample, they divided the sample into people who were ill for 18 months or less and compared their treatment response to those who were ill 18 months or 19 months or longer. And what they found here is there was a very important interaction between the length of illness and the care that you received. If you were in typical care, it didn't matter that much. This treatment delay, everybody got better. They didn't get better much, but they did get better, and they got better slowly. But in coordinated specialty care, if you offered this in the early months of illness, this line you can see here, people had a much more robust response to treatment than any other group. They got better faster, and this was across all of those dimensions. In terms of symptoms, functioning, quality of life, this result held up. So it told us an important thing. It's important not only to offer good care, but it's important to pay attention to the timing of that care and to organize systems so that, in fact, they were reaching people earlier and earlier. Now, since the study was complete and those findings were published starting in 2015, there have been some additional analyses of the RAISE data, some of them very positive. So we found that the medication strategy that was offered in the RAISE trial, which featured a computer-assisted decision support system for the providers, for the doctors and the nurse practitioners who are offering care, helped them to offer a higher quality of care that was more targeted to the individual's particular profile of symptoms. And when that was offered, not only did we get better results, but we were able to get those outcomes with less medication. So polypharmacy was really not a problem in the coordinated specialty care. And that although more people were on medication and stayed on medication for longer periods of time, there were far fewer side effects among that group. So this tells us something important about, it's not just that people take medication, but the way that we offer the medication, the way that we measure the impact of the medication, and the dialogue that we have with the person around medication choices are the best way of keeping them engaged over the long term. So that's a plus. The second analysis was, this actually was from a group here in Washington State that reanalyzed the RAISE data to look to see whether there were differences for people of racial and ethnic minority groups. And happily, the results showed that it was equally effective with people from traditionally underserved groups, racial and ethnic minority groups. So this tells us that there's something about coordinated specialty care that has broad appeal and broad effectiveness. That's a plus. On the downside, we found that the coordinated specialty care was not particularly effective in addressing substance abuse and alcohol problems among people with early psychosis. So this is a part of the model that needs more work and needs to be improved. And just this week, there was another study that was published by John Kane and his group that looked at, well, what were some of the predictors of hospitalization during the RAISE trial? And one of the strong predictors was alcohol and substance abuse after coordinated specialty care was initiated. So this is an area that requires further study. Now, all of that came from RAISE. That was great, but good science requires independent replication. If the same group is doing the work, that's great, but when another group does a similar study and gets similar results, you have greater confidence that maybe the finding is real. So here, at the same time that we launched RAISE, NIMH also supported an independent trial, the Specialized Treatment Early in Psychosis program that was run in Connecticut by Vinod Srihari and his colleagues. And this was another version of coordinated specialty care. All of the elements that I described before were part of this program. It was a intervention that was launched within the Connecticut community mental health system. So it was a public service model. And what they found here is that after 1 year, so it was a slightly shorter time frame from RAISE, but they found that not only did the coordinated specialty care improve symptoms better, but there was a positive impact on reducing the likelihood of hospitalization, and if hospitalization did occur, to have shorter hospitalizations, well, have a fewer number and shorter hospitalizations. In addition to that finding, they also found that the coordinated specialty care was a more effective way of re-engaging people in terms of school and work activities. So there was comparability across RAISE and STEP for symptomatic improvement, for vocational improvement, and also cost effectiveness. And in the STEP program, an additional finding about the impact of this treatment on the need for subsequent crisis intervention services. And then a third piece of confirming evidence came from the RAISE Connection program, which was the implementation study. The mental health authorities in New York and Maryland were actually so impressed with the results of the implementation project that those mental health authorities decided in 2013 that they had seen enough. They were going to implement this program statewide. And in New York, Lisa Dixon developed an approach called On Track New York, which now is a statewide program for early serious mental illness. And these results come from the first 10 programs that enrolled over 300 individuals and followed them for a year. This was not a clinical trial, but it utilized the treatments that were used in the clinical trial, and it applied a measurement-based care approach to monitor the fidelity of treatment and the outcomes achieved. And what you can see from this real-world observational study is not only were the results comparable to those of the RAISE clinical trial, but in some areas actually outperformed the clinical trial. So people, utilization of hospitalization reduced dramatically from baseline to the first 3 months of care and then stayed low throughout the year. Re-engagement with school and work doubled over a 6-month period. 80% of people were re-engaged with school and work by 6 months, and that stayed true over the course of the year. And this was, the pattern of improvement was pretty rapid improvement over the first 3 to 6 months, and then somewhat of a plateau, but a more gradual rate of improvement over the rest of the trial. So based on these findings, we could say for the RAISE research questions that, is the intervention feasible? Well, it turned out that between all of these studies, there were a total of 20 clinics where this model had been implemented in the United States, had been offered over a several-year period, and had been successful in achieving outcomes. So in real-world settings, this could work. That was good. Was the early intervention effective? Well, I just presented you information, data that suggests, yes, compared to usual care, it is more effective. The question about whether it was scalable remained to be addressed, and I want to tell you about that for a bit. So what I will say is, right up until now, I've talked to you about excellent science conducted by excellent scientists, and I can tell you after 20 years at NIMH, excellent science usually ends in excellent papers and doesn't do much more. You need something beyond just scientists to move to the next level, and this is where partners come in. So we started at NIMH with an idea that we wanted to work with other federal agencies to move this information forward. So right from the beginning, we were working with SAMHSA. After a period of time, we engaged with the Centers for Medicare and Medicaid Services, and the Assistant Secretary for Planning and Evaluation was also a tremendous asset in mobilizing the science into the policy arena. But what I didn't know I didn't know until about 2016 was the work that was happening behind the scenes from the advocacy community to put pressure to make these findings come into the real world. And here, I have to say, a tremendous debt of gratitude to NAMI for putting this issue in front of Congress, keeping the pressure on for Congress to respond to it, and make something happen in the world based on these scientific findings. So thank you all. And where NAMI was applying the hammer, we had allies such as the National Association of State Mental Health Program Directors that were giving us a way to talk with state mental health authorities about how they might be able to do this. And then also we saw around this time a tremendous surge of interest in this approach and the creation of a learning community of clinicians, administrators, and service users. PEPNET is the Prodrome and Early Psychosis Prevention Network. It's now run out of Stanford University. Steve Adelsheim and Kate Hardy are the principal leaders of that group, and they really have helped to create a forum for which all interested parties in this kind of a treatment approach in the United States can come together to share learning, to share training, supervision, ideas, and so forth. So many things happen to create some momentum for moving this science forward. But perhaps none of it was as, money talks and something else walks. the NAMI's pressure convinced the Congress that they should invest in this kind of approach. And in 2014, there was an item that was added to the omnibus funding bill that said Congress is going to give an additional $25 million to SAMHSA, and Congress wants SAMHSA to set aside that money to implement first episode psychosis treatment programs such as those tested in the RAISE program. And they further said SAMHSA and NIMH need to work together to provide guidance to make this happen and to help the states in achieving this. And it led to a very happy reunion of NIMH and SAMHSA around this issue that has continued to today. States were a little hesitant in 2014 to jump into this area. They were wondering whether this was a one-off. So Congress continued this through the appropriation cycle in 2015. In 2016, they doubled the amount of money for the set-aside. And in 2017, the 21st Century Cures Act actually moved this from appropriation to authorization and made this the law of the land, that 10% of the SAMHSA mental health block grant monies are reserved for programs that focus on early serious mental illness with an emphasis on first episode psychosis. So while we were doing that, I'm actually going to move a little quickly now because I other things to get to. We were, SAMHSA, NIMH, and CMS worked together. CMS blessed Coordinated Specialty Care as an evidence-based treatment program, and through the Medicaid program, published ways in which states could apply for waivers to be able to use Medicaid funds to support the full program, which was a big win for us to get CMS on this. So all this comes together. How did that impact bringing CSC to scale? Well, this side of the slide just gives you dates and milestones of the research, the funding, the SAMHSA NIMH efforts, and this graph here shows you what happened. So in 2008, there were 2 states that had plans. They were Oregon and Excellent, excellent, good engagement. So that stayed steady until the RAISE findings appeared in 2013, and there was I like to say there was a doubling of interest among the number of states. But, you know, a little bit of humility, this is what you get with science. That's what science gets you. You go from 2 to 4. But when you combine the science, the guidance, and $25 million, you see, you know, well, we went from 4 to almost a 10-fold increase in the number of states that committed to this approach. And now today, well, last year in 2018, there were 49 states. When you go to their mental health block grant plans, they have specific commitments to early psychosis and detailed plans about how they're going to do it. So that was pretty good. Now, how does that work in terms of the number of programs that actually exist in the country? Well, remember there was, in 2008, there were 12 programs. Now, buckle your seatbelts because the world changed 10 years later, and this is what the world looked like 10 years later. 265 programs across 49 states. And I apologize that not all the numbers made the transition, but if it's a yellow square, that means the state has between 1 and 4 programs. The blue, not square, circle. Blue circles are between 5 and 9, and the red circles are 10 or more programs. And what you can see here is that you know, there's quite a degree of interest, there's quite a degree of variability in how states have jumped into this, but it is a tremendous change in the landscape over a very short period of time. All of these programs, at least according to their reports, are constructed according to coordinated specialty care principles and are offering that for first episode psychosis. So when we look at that, is it feasible? Yes. Is it effective? Yes. Can it be brought to scale? Apparently so. We're making some really good progress in that regard. And we can look back and say, well, there's been a real decade of progress here, from very modest beginnings with a small number of states, a very small number of programs, a small workforce of clinicians and a very small population of people who were benefiting from this program. 10 years later, we've had a 20-fold increase in the number of programs that are available, the 10-fold increase in the number of clinicians who've been trained in this approach. And last year, from SAMHSA's report, there were 10,000 young people across the country that received this care. So not the full answer to the problem, but we're making progress. This is progress to be proud of, but not to be satisfied with. We need to be looking ahead, and what's the next challenge here? So I think the challenge is we have 265 programs. What would happen if we were able to connect them in a meaningful way and use those programs as a fulcrum for additional change and reform? So going back to the learning healthcare model, the general model says provide best care. Well, now we know for first episode psychosis, the best care is coordinated specialty care. That is the new standard of care. If you're not providing that care, you should be explaining why you're not providing it, because that's the standard. So in these programs, if they're providing coordinated specialty care, like Lisa Dixon's program in New York, we can ask, how might those results be improved if we measure results, we provide timely feedback to clinical teams about how effective their program is, we look for places where the program could be improved in terms of quality, and then we study variation in responses to learn more about first episode psychosis and the interventions that we have. Again, buckle your seatbelts, because at NIMH, I am unveiling our idea to create an early psychosis intervention network, EpiNet, out of this, really, without the PowerPoint presentation function, I would be nothing. So there's a lot of words on this slide, but it's our translation of how the learning healthcare principles that the IOM promoted could be adapted in a learning healthcare system for early psychosis. And basically, we're emphasizing that there should be standardization of assessment, and each clinical encounter should be captured in a way that we can gather information that will be informative about the effectiveness of care, that we would put together informatics tools that would be able to aggregate de-identified anonymous data in a way that we can look at it to look at trends in service utilization and outcomes so that we can embark on quality improvement efforts in a timely way. And then finally, the last thing that the IOM talked about was about creating a collaborative culture in these clinics and in healthcare systems where people receiving care, clinicians offering care, and researchers studying the care all have a common stake in being able to use science to improve outcomes. And when you think about it, this is kind of the brilliance of the cancer world. When you go into a cancer clinic today, they will tell you. So we participate in clinical trials, we participate in research. We use the data that we provide, or we use the data that we collect in routine clinical care to better understand cancer and its treatment. You're now part of that army. We're using your data to improve your care and to drive science that's going to improve care for people in the future. I would love to see that as kind of the hopeful ethos that permeates these programs, where we can say to people, we are offering you the best of what we have. We're accountable for what we do because we're measuring the results. We're constantly looking for ways to improve it. And we're using science as kind of the engine to improve care going forward. Please join us in that endeavor. So that's a new kind of culture that we would like to promote across these clinics. So NIMH we announced this opportunity last July. We received a very healthy set of applications. They've been reviewed, and we expect this summer we're going to be funding a number of them. So Since they're not funded, I can't give you specifics, but I can tell you overall the anticipated scope of EpiNet is quite large. There'll be 5 regional coordinated specialty care networks. That means that there'll be a series of clinics that are tied together by a hub that is responsible for this, driving this measurement-based care formula. Across all of these networks, there are about 55 clinics that have stepped up for this kind of participation. That's about 20% of the national resource that we have here. So that's a good fraction of the national pool. About 3/4 of those clinics are clinics that receive mental health block grant funds from SAMHSA to operate. So these are community clinics. These are real-world clinics. About 25% are academic research clinics. So this is a nice mix where you want academia and practicality mixing in a common venture. There were 2,300 people already enrolled in these clinics at the time that the applications were received, so that tells us that these are real. It's not just a promise that they would be created, they're actually operating today. And what was promised is that they would enroll in aggregate over 5,000 people over the next several years. And if we think conservatively that if each of those people, we roll up their progress data on a quarterly basis, we could be generating 20,000 observations about the impact of care per year. And we can use that for, I think, transformative purposes. And one is, I see I'm getting short on time, so this one I've talked to you about quite a bit. We can start with best care, and we can move from measurement to quality improvement to optimized care. So we see this as a way of using learning healthcare to continue to improve the quality of the services. There are research opportunities, and in fact, these networks have proposed some really important studies that get at unanswered questions about first episode psychosis, such as how do we reduce the length of illness before people get into care? How do we mitigate suicide risk in that crucial early period of care? How do we determine what the optimal dose of care is? How long should it be? How intense should it be? And then also utilize this as a platform for studies that may test new pharmacologic approaches in first episode psychosis. So using it as a way for people who are interested and willing that we could run practical clinical trials that would test different pharmacologic strategies. And then finally, as the world of early intervention continues to move forward, many of these programs have adopted, have expanded their services to take in people who are at clinical high risk for developing psychosis, who are help-seeking in distress but not yet psychotic, and offering them preventive care. What might we do to help that group? And here's my second love letter to NAMI. NAMI has really re-energized the conversation between the Stanley Center for Psychiatric Research at the Broad Institute, NIMH, and leaders in pharma around what would it take to generate new interest in developing better 21st century medications for people with psychosis. NAMI, yeah, you should. NAMI started this conversation in 2016 and has had a series of discovery summits where these stakeholders have been brought together to have these conversations. And just this past April, there was a meeting around, well, we've had several of these meetings, and now what would it really take to engage pharma in an endeavor that would look at new approaches for early psychosis? That meeting, and NAMI's leadership in that meeting to kind of push partners to state what they would be interested in, what they would find compelling, led us at NIMH to propose a new concept for research. This was just May 29th. This was proposed to the National Advisory Mental Health Council, that alongside EpiNet, we would create a network of clinical high-risk programs that would be engaged in research that would study biomarkers of illness onset, progression, and treatment response, and use that information as a way of identifying new targets for pharmacological intervention so that new studies could be conducted to meet that need. So National Advisory Mental Health Council endorsed this concept enthusiastically, so we are now developing an initiative around this idea. So going from first episode psychosis to people who are at imminent risk and doing this research in the context of routine clinical care is our vision. So as we do that, I'm coming up on my summary. We see partnerships have been essential for the progress that we've made so far. Our first partners were the scientists who willingly gave their talent and their energy to the RAISE trial. Our next set of partners were the advocacy groups who really had the passion and the commitment to push policy leaders to pay attention and to make some changes to bring these findings into the real world, and partners with a clinical community that has been energized by these findings and these possibilities and have created a real resource. So going together, persons with psychosis and their family members being the key stakeholders. This is like your needs are really what this is all about, combined with our clinicians who are forward-thinking and looking for data to improve their care, along with our early psychosis researchers who are going to look to push the envelope of knowledge continuously forward. This is the partnership that we aspire to. So in summary, early intervention improves clinical outcomes among people with first episode psychosis. Coordinated specialty care is feasible. It's an effective intervention for first episode psychosis. And EpiNet will test learning healthcare principles of science-driven, continuously improving care. And with that, I will just acknowledge members of my team at NIMH, Susan Azarin, Amy Goldstein, Joanne Severe, Michaela Scanlon, and our colleagues at SAMHSA who helped so much in the implementation of the science, Paolo Del Vecchio, Centrise Bellamy, Gary Blau, and Stephen Detweiler. And with that, thank you.